Good evening, everybody. Can I ask you to take your seats? Hello? Can I ask everybody to take your seats, please? Welcome everybody who's attending this evening at the Delta Hotel in Edmonton, and welcome to all of our regulated members who are joining us online tonight. My name is Greg Eberhardt. I'm Registrar of the Alberta College of Pharmacy. I'll provide some opening remarks, and through the evening we will then, I'll turn it over to Deputy Registrar Jeff Wissel and to Monty Stanowich to provide some, lead you through the program. We're fortunate to have a few council members here with us this evening. From district number, where do I want to start? 3, just because I see him, Murtaza Hassan Ali. From district 1, Asad Karani. And I know if I look around, have I missed somebody else? Maybe we have 2. So 2 council members here, and we have a number of members. I'm sorry, Kirsten Sheeran from District A, the Pharmacy Technicians. And there's a number of members of our administrative team joining us this evening. Unfortunately, President-elect Pat Thompson has not been able to join us to lead this evening's discussion. In going through the discussion this evening, we will have a panel discussion after. The panel discussion will focus on questions related to the standards of practice. If you have any questions that are related to issues outside of the standards of practice, we would ask that you address us after the meeting is over. Again, members of the administrative team will be here, and we're happy to engage with you on that note. So welcome to ACP Connect. Thank you for taking time out of your busy schedules and joining us this evening. Before we begin, the Alberta College of Pharmacy respectfully acknowledges that we are gathered in person and virtually on Treaty 6, Treaty 7, and Treaty 8 territory, the traditional lands of First Nations people and 6 Métis regions. The roots of many modern medications come from the Indigenous people's traditional use of plants from these lands. Tonight we're here to discuss ACP's new standards of practice for pharmacists and pharmacy technicians, which were approved by Council in June of 2024 and will take effect along with the new standards for the operation of licensed pharmacies on February the 1st, 2025. We'll begin with a short introduction to discuss why the new standards and why now. We'll also explore expectations of regulated members and how you might prepare to successfully implement the new standards once they take effect. Deputy Registrar Jeff Wissel will then discuss the process ACP used to develop the new standards and explain how the new standards are structured. Then Policy Lead and Compliance Officer Monty Stanowich will take us through a tour of each domain of the new standards and highlight some of the key changes to the standards that regulated members should take note of. After a short break, the 3 of us will participate in a panel discussion moderated by ACP Communications Director Barry Strader. At that time, we'll invite you to ask questions to our panel about anything related to the standards of practice for pharmacists and pharmacy technicians. So let's begin. Why now? When you heard about ACP coming out with new standards, you may have thought to yourself, why new standards and why now? The short answer is that ACP's current standards have been in place since 2007, and it's time to refresh. Much has changed in pharmacy and healthcare in general. And since these standards were introduced, they've been amended and updated here and there during the past 17 years, but the time has come to readdress the standards holistically. Ensuring that there is a modern and relevant framework to regulate pharmacy practice is the second of our 5 goals as part of ACP's 2021 to 2025 strategic plan. As part of this goal, a key objective is that standards are current, relevant, clear, concise, and appropriately balance inputs, processes, and outputs. Thus, Council tasked the ACP team to develop new standards to ensure this objective would be met before the end of 2025. Person-centeredness is at the heart of these new standards, with a focus on patient outcomes rather than processes. These new standards address more than just prescribing or filling a prescription. We're aiming to support the health interests of our patients. We think the new standards reflect the way many regulated members are already practicing and will serve us for the foreseeable future. The world of healthcare is an ever-changing landscape, but I think these sets of standards, there's more flexibility to ensure that we can continue to grow. With this in mind, the new standards will enable pharmacy teams to successfully navigate what lies ahead for themselves and Albertans. These standards are intended to benefit the public. A real effort was made to ensure the new standards are written in plain language as opposed to interprofessional jargon. Because of that approach, Albertans will be able to see themselves in the standards. They'll be able to understand not only what the words say, but what is the intent of the words. And I believe the way the new standards are outlined is an opportunity for regulated members to more clearly see themselves in their role and to see how the role can be enhanced through the standards. So what about expectations? First, to reflect, the standards are authorized through the Health Professions Act. The Health Professions Act establishes a role for each profession and authorizes the development of regulations and standards, and it sets the responsibilities and accountabilities of regulated members performing their roles. So everything comes back to the Health Professions Act, the roles for pharmacists and pharmacy technicians in the Health Professions Act, and keeping in mind that the Health Professions Act was established to establish our role as health professionals in delivering health care. In every circumstance, a regulated member's authority to engage in the practice of their profession must be interpreted and applied in the context of the role established by the Health Professions Act, the Health Information Act, and the directions provided through regulations, standards of practice, the college's code of ethics, the relevant guidelines, and acceptable conduct. The Code of Ethics reflects the ethical commitment of pharmacists and pharmacy technicians to society, to patients, and to our professions. The Code of Ethics provides regulated members with guiding principles for professional behavior, attitudes, and actions, and is foundational to the practice of pharmacy through these standards. The standards need to be considered, applied, and implemented with Code of Ethics as a background foundation. Let's talk about the role of the pharmacy team. These standards differentiate between the clinical role of pharmacists and the technical expertise of pharmacy technicians when providing professional services. Together, pharmacists and pharmacy technicians work in partnership to provide care to patients. At the core, pharmacy teams are responsible for the integrity of drugs that patients receive and to ensure that patients receive appropriate therapy. While compliance with the standards is mandatory, regulated members may engage in different practices depending on the needs of the community, the populations they serve, their own competencies, their practice environment, the nature of their practice, and the role authorized for their profession. So let's talk a little bit about culture shift. If you turn the clock back, pharmacy in Alberta was first authorized to develop standards of practice in 1995. That's less than 30 years ago. At that time, pharmacists were largely compounding, dispensing, and selling drugs. Standards were very prescriptive and very input and process oriented. As we moved to 2007, pharmacy technicians had not been contemplated yet. In 2007, the landscape changed. Pharmacists received new role statements. With those role statements, certain restricted activities were authorized and enabled. But the restricted activities need to be applied and interpreted in context with the role statements. And therein lies the subject of ensuring that those restricted activities are applied in the context of providing health care. In 2007, we went through a significant transition, a moment in time which I don't think we as an organization or we as a profession really recognized the massive change that we're going to be going through. And even today, in 2024, we continue to go through a very significant culture shift. The shift of focusing from prescriptions and drugs to focusing on people. So in 2007, and the standards that we've been working with over the course of the past 15 years, they're a hybrid model. They're still very prescriptive. They're still very input-oriented, introducing concepts of clinical practice and patient care. And now, in 2024, we're taking you into the new world. The world where the practice of pharmacist is about people. It's about patients. Assessment is a new word on the street. Everything that pharmacists and pharmacy technicians do must be based on assessment and critical thinking. Assessment is foundation to all care and services. It comes before decision to dispense or prescribe. Failure to effectively assess introduces risk, gaps in care, and cost to individuals, families, and the health system. Critical thinking is complementary to assessment. It adds additional knowledge and judgment to information collected during assessment. It must be evidence-informed. Practitioners need to understand their limitations. They need to know when to consult, when to collaborate, when to refer. It's important to understand the balance between just because we can doesn't mean that we should, versus understanding when we need to step forward and to perform. Gaps in care may relate to liability either by omission or by commission. So how do we prepare to implement this? I hope that through this evening's discussion, you'll achieve a greater awareness of what the new standards cite, how they're structured, how you interpret them, how you apply them. I think one of your greatest considerations leaving this evening is to try and understand and be able to discuss with your team about how to achieve an outcome-based standard as compared to a prescriptive standard as we've been accustomed to in the past. I would encourage you all to evaluate your practice and develop plans for change. You'll need to make necessary changes to your practice, including changes to policies and procedures. So looking forward, key dates for all of us. The standards come into effect on February 1st, 2025, with the exception of one standard within the standards for the operation of licensed pharmacies, which relates to the requirement to have a real-time interface with Alberta Netcare. Today, nearly 60% of pharmacies are working in a real-time environment, and the time has come, in the interest of the continuity of care and in the interest of patient safety, that we all move to that ultimate end. By delaying the implementation time period, I believe that it provides opportunity for pharmacists to work along with Alberta Health and your service providers to ensure that that can be achieved. So thank you all, and I'm going to turn it over to Deputy Registrar Jeff Whistle to talk a little bit about the structures of the standards and to assist you in that journey of understanding how you interpret them and apply them. Jeff?
Thanks. Good evening, everyone. It's fantastic to see so many of you here on a great September evening and have so many people online as well. Really appreciate it. I'm going to begin with just describing the journey in creating the new standards and talk about some of the key things that were important in implementing the new standards. And you can imagine that when creating standards, it's a little bit overwhelming to know exactly where to start. And so we decided we would start with principles. And I'm going to share a couple of the principles that Council outlined for us to guide us as we created these standards. And these principles are key because they're things that we hope to accomplish as we got to the end. And I think we probably have accomplished them. And so just to begin with, we wanted to write standards that were really focused in patient assessment. Every day, all of you in this room, you make assessments about the patients that you're caring for. And so we wanted to really reinforce that. And our current standards speak more to prescription assessment. We wanted to, as Greg said, bring the focus back to the patient and make sure that when someone comes in, that you start with an assessment before offering them a professional service, whether that be prescribing, dispensing, compounding, or providing them a drug by injection. We next wanted to ensure that the standards could be applied in all practice settings. And one of the things that we've heard from regulated members is at times the standards didn't work well for them or they didn't see themselves within the standards. So we hope that these standards enable you to see yourself in them and to provide guidance to you in your practice. Greg touched on this, but it was important to us that the standards be outcome focused and that you understand through those outcomes why you were trying to achieve the standard, and that the public could easily look at those standards and certainly understand what to expect when that standard was met. The standards are meant to be considered carefully by the regulated member, and you have to think about how they might fit best in your practice. So you have to critically assess the standards. We've tried to be precise where precision allows, but it's important that everyone familiarize yourself with the standards and reflect on how they might guide you in your own practice. And then, importantly, we wanted the standards to more fulsomely consider the role of pharmacy technicians. When our existing standards were really structured and written, that was back in 2006, 2007, prior to the regulation of pharmacy technicians, which didn't occur until 2011. And we certainly amended the standards in 2011, but we kind of bolted on pieces about pharmacy technicians to the existing standards. So we wanted to start from the ground up with pharmacy technicians in mind. And so that's one of the other key things that guided us. And so you'll notice that the standards really talk about regulated members. They do talk about pharmacists and pharmacy technicians and do try and identify where role overlap exists. So what informed the development of the standards? And we started with a really comprehensive environmental scan, and we started looking here in Canada, and we looked to all the different pharmacy regulatory authorities in Canada and tried to learn what opportunities existed within their standards and what some best practices might now be. So we really informed ourselves by looking across Canada. But then we went a step further and we looked at the National Association of Pharmacy Regulatory Authorities and what they'd done with their standards because they'd recently revised those too. And we learned a lot about how to structure our standards from NAPRA. We then went international and wanted to determine what other countries were doing with pharmacy practice standards. And so we looked at the United States, the UK, we looked at Ireland, we looked at the Netherlands, Portugal, South Africa, New Zealand, and Australia. And we tried to understand some of the lessons that they might have learned and some of the best practices that they adopted into their standards. And then finally, we also looked at other professions. And so in Alberta, we specifically looked at the College of Physicians and Surgeons, the nurses, and the physiotherapists as well. And finally, we looked to some of our key partners. We looked to the University of Alberta, we looked to the Institute for Safe Medication Practices, and the Health Quality Council of Alberta. So a lot went into informing the standards. When we started to develop the standards, we used a multi-stage process. And the first thing we did is we worked with our internal team, many of which are here this evening. And we tried to learn from their experiences in what they'd heard from our regulated members and what they heard from the public, where they saw strength in the standards and where they saw weaknesses. And we gathered that up and started to create the standards. And in doing so, we worked with a small group and a diverse group of external reviewers. And this was a group with different backgrounds, from different cultures, different values, who could bring forward a rich diversity. And we included pharmacists, pharmacy technicians, and members of the public. And they helped guide the creation of the standards as you see them today. We, of course, also work closely with ACP Legal Counsel as they had an important role in developing the standards. We then took what we developed and we conducted a 60-day external consultation. And through that consultation, we learned a lot and we collected a lot of feedback. In fact, thousands of pieces of feedback were collected from regulated members, from other health professionals, and from the government and other agencies like our own. And we carefully considered each piece of feedback, as well as tried to identify key themes in the feedback. And we started to make improvements in the standards based on that consultation and what we'd received. The standards were then shared with Council at their June meeting. Council requested some changes to the standards, and those standards were approved, and that's what brings us to today. So looking at the standards themselves, there's a couple of key sections that I just want to take a moment to outline for you. And the first section is the introduction section. And this is just the best place to start with the standards as you sit down and begin to read them. And the introduction section covers off important things about the legislative framework, the role of the pharmacy team, person-centered care, and animal health. And so all of that is placed up front. The next section deals with interpretation and application of the standards. And this gives you some guidance on how you should read the standards and how you might want to apply certain concepts throughout the standards. So a great example here is within the interpretation section, you'll note that anytime we say patient, we also explain that we mean the patient or the patient's agent, instead of repeating that throughout the standards. So it's just a good piece of interpretation. The next section is the definitions section, and the definitions, many have been carried over from the existing standards, but of course we had to introduce some new definitions as well to address some important concepts that we were really interested in. One thing we've avoided doing, though, is duplicating definitions that might occur elsewhere in the legislative framework. And then finally, the appendices. Most of what you see in the appendices will not be new to you. In fact, you'll probably be really familiar with it. But one of the things our regulated members told us is informed consent was challenging, and they were faced with challenging situations like how to address mature minors and issues like that. So you can certainly read about some of the expectations of working through informed consent in Appendix A of the standards. One of the most significant changes in the standards is right here on this slide, and it's the introduction of domains. And so our current standards really don't have any organization. They're a long list of kind of expectations, I guess. And when we conducted our environmental scan, we couldn't find anyone who wrote standards like that. So we thought it really important to introduce a structure. And so we've introduced the 8 domains that you see here on the screen. One of the critical things that we wanted to be able to do is put a focus on person-centered care. And so everything that we do as pharmacists or pharmacy technicians is about the patient at the end of the day. And when we write standards, they're always about the patient. And so that's why you see the patient at the center extending out into all the other standards. And you'll also note that it's surrounded by professionalism and leadership. And what you are as a professional and a leader within your own practice influences how you conduct yourself with the expectation of all the standards and how you might meet those. To provide context for each domain, we've created a domain statement. And in creating that domain statement, we've tried to describe what's expected within each domain and what each domain seeks to accomplish. One of the key things that we're really excited about with the person-centered care domain is the emphasis on equity, diversity, inclusion, and accessibility. And in creating these standards, our regulated members really told us that this is how they like to provide care, that this is what they value, that this is what their patients value. So we wanted to bring a great focus to that person-centeredness and treating individuals with respect and dignity. As we look to the structure of the standards themselves, you'll notice each domain is numbered 1 through 8. There's a domain statement, as I discussed, and then the domains are broken down into topics within each area. And this is kind of the level of the organization of our existing standards. You'll see topics within there. Each topic has an outcome standard, and then which is numbered 1.1 or 1.2, usually 2 digits. And then each outcome standard will have a descriptive standard that helps to provide information on how that standard might be achieved. So as an example, we have here domain 4, which is knowledge, skills, and judgment. The partial domain statement is maintaining competence is a professional responsibility of regulated members. The topic is knowledge and skills to manage emergency situations. The outcome standard is a regulated member must ensure patients receive appropriate care in an emergency by maintaining the knowledge and skills and exercising the judgment required to manage emergency situations. And then the descriptive standard here is a pharmacist who is authorized to administer drugs by injection must maintain current certificates in CPR and first aid at a level determined by council. So that gives you an idea of the overall structure of the standards. I'm next going to invite Monty Stanowich up, Policy Lead and Compliance Officer with the Alberta College of Pharmacy, to take us through the domains and highlight some of the key changes within each. So thank you.
Hey everyone. So I'm here to speak about the domains and specific changes to the standards. And one thing to clarify up front is that while the appearance, format, and organization of the document may have changed dramatically, much of the current content still exists in the new standards. So think of these changes not as a complete rewrite, but rather as an evolution. Pharmacy practice has evolved since the current standards were published and will continue to evolve. The standards are an evolution of expectations that bring us up to date with modern pharmacy practice and position us to move forward into the future. Having said that, though, much of the core of what pharmacy practice is remains the same. So when you look at Domain 8, for example, on dispensing and compounding, much of what you see there will be very familiar. When we first started reviewing the standards, some of the material was out of date, so it was updated and removed altogether. Keep in mind that in 2007, prescribing was a step into the unknown for pharmacy. In 2024, pharmacist prescribing is an established and essential part of healthcare in Alberta. The expectations, direction, and support provided by the standards need to reflect that. Even standards that remain essentially the same have been reorganized and the language has been updated. Finally, there's some new standards that have, will impact pharmacy practice, and it's those that I want to spend a little bit of time discussing. So Domain 1, person-centered care. This is the very heart of the new standards, a concept that influences the other 7 domains and is foundational to every aspect of pharmacy practice. That's why this domain is in the center of the diagram. It's the core. Stated simply, person-centered care occurs when professional services are delivered in an approach that recognizes the patient as a partner in their care. As described in the standards, ways that regulated members can demonstrate this are meaningfully involving patients in the decision-making processes, genuinely caring for the well-being of patients, developing positive and trusting relationships, working with the patient to support their care and advocate for them, respecting their privacy and autonomy and their dignity and rights without any prejudice. Person-centered care recognizes each patient as an individual with their own values, needs, and health concerns. Regulated members collaborate with patients in order to understand what's important to them, and then they have to adapt the care they provide to meet each patient's needs and health goals. So some of the key topics in this domain are professional relationship with patients, as Jeff mentioned, equity, diversity, inclusion, accessibility, informed consent, confidentiality, and continuity of care. So as mentioned, person-centered care is more than just a domain. It's the core of the standards, and it means that every standard written and every action a regulated member takes affects the care of a patient. So consider, even with the standards that don't directly involve patient care activity, the standard exists in some way to support patient care. So the key point here is that while Domain 1 contains standards that I'll speak to in a moment that address person-centered care, you have to look at all the standards through the lens of person-centered care throughout the entire document. We had a lot of feedback about the use of person-centered care versus patient-centered. After all, we're healthcare professionals and we're working with patients. And while that's true, it's important to remember patients are complex individuals, and being a patient is only a small part of their overall persona and of their life experiences. Who they are, what they believe, and what they've experienced as a person are all important considerations for regular members to consider when providing care. So, as I said, much of Domain 1 is new content, but as Jeff mentioned, it reflects what already is occurring in practice. So, the outcome standard 1.2 on equity, diversity, inclusion, and accessibility states that regulated members need to recognize and value the diversity of patients and ensure they have access to quality pharmacy care. So that's the outcome you need to achieve. Essentially, it says treat all people respectfully and give them what they need to support their care. And from what we know, this is already an unwritten standard in pharmacy. Pharmacy teams are very good at treating patients this way. The descriptive standards that follow are there to help support how to achieve this. Things like respecting the dignity and rights of each individual without prejudice, understanding and acknowledging your own bias. But really the outcome here, again, to recognize and value patient diversity and treat all people with respect and give them what they need for their care. That's it. I want to take a moment to discuss the concept of accessibility. When speaking of accessibility, people tend to think of wheelchair ramps and physical access. And while this is certainly a part of it, it means much more than that. So there's a standard 1.2.1a that focuses on this, and it requires that a regulated member must consider physical, cognitive, and sensory abilities, level of health literacy, and the level of digital literacy of patients. So think about patients that have hearing deficits or patients who are blind. How do you provide them and accommodate their care? What about patients who struggle with English? With digital literacy, does your pharmacy require patients to access online content? How do you provide care for those who aren't computer savvy or don't have access? Having resources linked to a smartphone app can be great, except for that 82-year-old patient who has a landline and a flip phone. So the standard reflects the need to provide care to those who have a limited understanding of health and healthcare, and those who might not be able to access or understand online services or technological devices. Other key changes in Domain 1 relate to cultural sensitivity. Again, this comes back to the fact the individual in front of you is a patient in that moment, but they're also a person, and you have to consider their culture, values, and beliefs may influence the way you provide them care. So the expectation here is not that you need to ask specific or intrusive questions, but rather you acknowledge that culture may play a role and create an environment where people feel comfortable talking about that. An example that came up frequently while we were developing the standards was about helping a Muslim patient adjust their dosing schedule during Ramadan. Often this can be a simple change, but very meaningful to that patient. We created a separate standard for Indigenous patients, as this group faces unique challenges in the healthcare system. This standard seeks to acknowledge this and to meaningfully address it. With respect to stigma, trauma-informed care, and harm reduction, again, the focus here is on supporting patients and regulated members. We strongly believe regulated members value these things and are already doing them well. These changes are reflective of best practices observed in the field. To find evidence of this, we only need to consider the community-based naloxone program. Almost 1,600 pharmacies participate in this program, and they've provided tens of thousands of kits to individuals since 2017. Last year alone, there were over 16,000 reversals reported using naloxone kits. Pharmacy teams here are literally and measurably saving lives with this harm reduction measure. Further to that, pharmacy teams work with patients and prescribers like the Virtual Opioid Dependency Program and provide treatment to some of these individuals. So pharmacy is there for every step of the journey to provide care without judgment. This is what's going on in practice, so the standards may be new, but they reflect these practices and support you in delivering this care. Another key change of Domain 1, key change to the standards, is around informed consent. So this is mentioned in the current standards, but only in certain sections like injections and prescribing, not in a big picture sense. So here it's applied to everyone, but it looks different different for different patients in different circumstances. What's important to understand here is that patients need to understand their care and are informed partners in it. So this is not meant, informed consent is not meant to be a checklist or a script. What it looks like depends on the situation and the patient. So you as the health professional have to be 100% satisfied you have the patient's consent. And this looks different for somebody getting a shingles immunization compared to someone you're prescribing an antibiotic for, compared to someone getting a monthly refill of their long-term medication. People asked us for a definition of informed consent, and as Jeff mentioned, we did one better, and there's a 2-page appendix on it. Because it's important, it's fundamental, but it's also very nuanced, especially with respect to minors, those using a patient agent, or adults who don't have the ability or the capacity to consent. So Domain 2 now, professionalism and leadership. These are fundamental to everything regulated members do. Professionalism and leadership, it guides the action of regulated members in carrying out their duties in each domain. In the domain diagram, it creates the outer circle. And this was purposeful because it touches each domain and forms the outer boundary of pharmacy practice. Nothing in pharmacy exists outside that boundary of professionalism. The standards support and align with ACP's existing professionalism framework. Professionalism is demonstrated through altruism and ethical conduct to promote the health of individuals and their communities. People feel genuinely cared for, and members of the public and colleagues have confidence, respect when professionalism is demonstrated in practice. Each regulated member has an opportunity to be a leader in their own practice through collaboration and through mentoring of co-workers and colleagues and students. Some of the key topics in this domain are leadership and culture of accountability, physical work environment, and supervision. So the standards make some key changes when it comes to unregulated employees and how they're supervised. Unregulated employees like pharmacy assistants play a limited role with respect to restricted activities. Essentially, their role in patient care is to support regulated members, but all the accountability and responsibility of the standards lies with the regulated member and not the employee. What we did here is we replaced the concepts of direct and indirect supervision with critical steps and independent double checks. Direct supervision is defined as eyes-on and available to immediately intervene. Indirect supervision means you're readily available, but not necessarily in the immediate area. From a practical sense, neither one of these concepts worked quite well all the time. So we introduced the concept of critical steps. This is intended to ensure patient safety, but also to accommodate and facilitate pharmacy workflow. Critical steps are defined as a step in the process that must be reviewed during the process, as it cannot be confirmed during a final check. In other words, it's a hard stop, because if the process carries on beyond that point, it's not possible to ensure the step was done safely or correctly. An example would be weighing a chemical to add to a non-sterile compound. So you as the regulated member doesn't need to stand there and watch the employee select the chemical off the shelf and weigh it out. You can go at other parts of the pharmacy and do whatever you're doing. But before the compounding can continue, the regulated member will have to come over and do an independent double check to ensure this step was completed correctly and safely. It's because you can't do the check after the compound is mixed together and the chemicals are placed back on the shelf. There's a standard 2.5.3b which outlines critical steps for non-sterile compounding. But for all other activities, the regulated member needs to kind of assess what's being done, and these steps need to be set based on need. You know, things like a DIN check, for example. Had a lot of questions about whether an independent double check refers to a tech check or a pharmacist check. And while it's a great practice if you have the resources, this is not the requirement. An independent double check by a regulated member is only required for unregulated employees because they're not authorized to perform any component of a restricted activity otherwise. So of course it's expected that that employee will do a check of their work, but since only a regulated member is authorized and accountable, they must perform that independent double check before work can continue. Domain 3, this domain is around communication and collaboration. The purpose of communication is to create a shared understanding through the flow of information between regulated members, patients, and the patient circle of care. It's meant to empower patients to meaningfully understand their care and to participate in decisions about it. It further informs colleagues in the patient circle of care, colleagues and others in the patient circle of care. Collaboration relies on effective communication and occurs when regulated members work with individuals within the circle of care, and they work together cooperatively and collaboratively to meet the patient needs. So key topics in this domain: effective communication with patients, collaboration with individuals in the patient-centered circles of care, and collecting patient feedback and managing patient concerns. So a small but noteworthy change here is we've expanded the definition of patient's circle of care beyond just other regulated health professionals and patient agents. It also includes caregivers and other individuals who work in collaboration with the patient, such as those at community agencies and programs, and any others really who are actively responsible for elements of providing or supporting patient care. The concept forms the basis of a team-based approach with the patient right in the center. Again, this is what we're seeing in practice. There are other individuals who are involved in administering drugs, in helping the patient obtain coverage, in helping the patient enter a facility, etc. Regulated members can and should work with these individuals as part of the patient circle of care. Again, a team-based approach. Domain 4, this is knowledge, skills, and judgment. So maintaining competence is a professional responsibility of regulated members. In order to provide that safe, appropriate, and effective care, every regulated member has to ensure they have the knowledge and skills to make the professional judgments required. But equally important, every regulated member must understand the limitations of their own personal competence and further work to anticipate what they don't know. I mean, key topics in this domain are developing and maintaining professional competence, evidence-informed practice, professional practice, and restricted activities. So key change in Domain 4, but also in Domain 7, is around decision-making. So the new standards place a strong emphasis on evidence-based information and evidence-informed decisions. So what does this mean? When we examine these concepts, you'll find they're both defined in the standards. Evidence-based information is information based on research from credible and reliable sources that's applicable to the particular problem or situation you're considering. This is talking about data and about information that is high quality. If you're using data or information to base your clinical decisions on, you need to use your critical appraisal skills to evaluate that data and determine its relative worth. Now, evidence-informed, this is the process. This is where you take the data that you've evaluated already and evaluate it all to make a clinical decision. Remember, a key point here is that you're using the data to determine the best alternatives. You're not making a decision in advance and then looking for data to substantiate it. The process here is meant to inform your decision and inform your choices. For example, if you're managing ongoing care and want to add or change a patient's drug regimen, using published Canadian clinical practice guidelines would have far more value than using a single independent study. As an example, I once saw a prescribing decision that was kind of contrary to established clinical guidelines, and it was based on a study done in Kazakhstan in the 1990s that had 9 patients. And while that study, it's more evidence-based than a Google search. On its own, it's not great quality evidence, and a critical evaluation would clearly demonstrate that. Now, having said all this, the process remains person-centered, of course. Patient choices, values, and circumstances must be considered as part of the decision-making process. The patient's a partner in their care, and this is a critical factor regardless of evidence. So there may be times when you pick a drug that's administered once daily as opposed to 3 times daily because the patient has limitations on when they can take the drug. So again, the patient is a key consideration. So regulated members provide health services to patients. This encompasses a broad range of activities, and what these look like is defined in the Health Professions Act. Personal services are different. They're primarily focused on aesthetic applications, and they're regulated by the Personal Services Regulations. Among these activities are the applying or injecting of cosmetic products. There is no legislative basis for a regulated member of ACP to provide a personal service within their practice or to hold themselves out as being capable of doing so. This doesn't mean the standards prevent regulated members from injecting neuromodulators or fillers for aesthetic purposes. It means they may not hold themselves out as a pharmacist or pharmacy technician while doing so, and they can't do it from a licensed pharmacy. Essentially, injections for aesthetic purposes are outside the scope of practice for regulated members per the legislation in Alberta. As a result, 2 standards were added, 4.3.2, which prohibits a regulated member from holding themselves out as a regulated member if they provide any services that fall outside of their scope or involve personal services, and 7.7.3, which specifically prohibits injections for aesthetic purposes. This is not unique to Alberta. 8 of the provinces have similar, if not more restrictive prohibitions in place. Domain 5, this one focuses on public health and health stewardship. The COVID-19 pandemic really demonstrated the important role that pharmacists and pharmacy technicians perform in communities when it comes to the delivery of public health programs and health stewardship. Without pharmacists and technicians playing this role, Albertans would have had fewer options and fewer opportunities for care. As far as changes, I mean, most of Domain 5 is new, and it consists of the 2 sections, public health and health stewardship. Public health refers to regulated members contributing to the health and safety of the community, including pharmacists supporting public health and safety measures. Pharmacy teams make a massive contribution to the health of Albertans by supporting public health measures around influenza, COVID, other publicly funded immunizations. Going beyond this, pharmacy teams inform and direct patients to other public health sources and resources, everything from the naloxone kits to STI clinics. Health stewardship means going beyond patient care even, and ensuring that regulated members mitigate the negative societal and environmental impacts of everything they do. Again, this is reflective of what's already happening in practice. Minimizing wastage, using health resources responsibly, like not ordering 20 lab tests when 2 will suffice, and safe drug disposal, which we see in community pharmacies. While some might think of this as operational in nature, we think it's important to ensure that all regulated members take a responsibility for these standards. Domain 6. This domain, it focuses on continuous quality improvement. Safe patient care relies on a culture in which all pharmacy team members are genuinely committed to ongoing improvement. Risks to patients are uncovered through a structured process that includes reporting, identifying contributing factors, and a culture of learning, not a culture of retribution when incidents and close calls occur. Patients are meaningfully involved in the process if concerns are identified. So this domain will support CQI+, ACP's Continuous Quality Improvement Program that will be launched later this year. CQI+ takes the concepts and standards in Domain 6, expands on them, and operationalizes them by providing a comprehensive quality improvement program for pharmacies. A key part of CQI+ will be the reporting of medication incidents and close calls. Some of the key topics in Domain 6, safety culture and just culture, prevention of practice incidents, managing practice incidents, and analysis of practice incidents and close calls. Domain 7, now this is a big one. This addresses patient assessment and providing care. Patient assessment and person-centered care are the focus. These standards provide a foundation for patient assessment that emphasizes critical thinking and requires appropriate monitoring, follow-up, and documentation. Based on an assessment, the standards define the expectations and requirements for professional services that regulated members might provide, like dispensing, prescribing, or administration of drugs. Key topics are providing patient care, prescribing drugs, administering drugs, and vaccines. So Domain 7 was informed by the patient care process taught at the U of A Faculty of Pharmacy and Pharmaceutical Sciences. The domain itself seeks to replicate the stages of the U of A process and includes patient assessment. It includes the standards on restricted activities related to prescribing and providing drugs by injection. But most importantly, it focuses the assessment on patients, not on prescriptions. Domain is laid out in a manner where everything starts with an assessment, and then through an evidence-informed process, various treatment options are identified and selected, and then patients are monitored, followed up upon, and then everything is documented. Key change in this domain, as I mentioned, everything starts with an assessment, and then as part of that assessment, their treatment options are selected. So two sort of new but not new treatment options. One of them is deprescribing. So this is the planned and supervised process of a dose reduction or stopping a medication that might be causing harm or may no longer be of benefit. This is a proactive preventative measure to assess a patient's medication and make changes before any harm occurs. Something pharmacists are currently doing, but there's nothing in the existing standards to really guide or support this practice. So we included deprescribing as part of the standards for APA prescribing. And the reason for this is because deprescribing includes the same considerations as initiating a prescription or managing ongoing therapy. For example, increasing a dose to the effective level for a patient, that's managing care. Reducing a dose to an effective level for a patient requires the exact same skill set and the same assessment, also managing care. So this doesn't mean a pharmacist without APA shouldn't deprescribe if appropriate. For example, if a patient's having an adverse reaction, the pharmacist can stop therapy, but they'd be expected to collaborate with the prescriber for an alternative solution. A pharmacist with APA can also collaborate, but they may prescribe an alternative solution themselves. The second change here lowers the injection age from 5 years to 2 years. This change was undertaken for a variety of reasons, one of which includes public need. So pharmacists frequently reported to ACP that family members of patients who are under 5 struggle to access immunization services. And there's frustration when you take your whole family to the pharmacy, and then you have to seek a different provider for those who are under 5 years of age. Another reason to support this change is that across Canada, only Alberta, Saskatchewan, and Yukon have a 5-year age limit. BC allows 4 years of age, and other provinces range from no age limit in certain circumstances to 6 months to 2 years of age. So this is a well-established pharmacy practice in which Alberta has actually been lagging behind. There's a standard 7.7.2b3, which requires the pharmacist to have training specific to the age group, route of administration, etc. So what this means is unless you already have training in this age group, it's expected that you'll take the required training to build competencies before providing injections to this age group. One of the benefits here, maybe of not being the first province to authorize this, is there are already multiple education providers offering this content. RxA this week announced that they're partnering with the Ontario Pharmacists Association and will offer training through their website at a discounted rate for their members. That's a local option. There are other options available as well that you can take. Important to note here, because you've already received training in order to obtain your authorization to inject, the coursework here doesn't need to be in-person training, although some do offer that. The differences here focus on, in this age group, focus on landmarking, administration techniques, pain and anxiety reduction strategies, and this can be done through a virtual or online course. Domain 8 now. This domain addresses drug distribution and compounding. As I said, this is probably the most familiar domain because much of the content comes from existing standards. So this includes technical functions of dispensing, selling, compounding drugs. The accuracy and safety of drug distribution supports the achievement of health goals. These activities are critical for success. Key topics include dispensing, packaging and labeling, the final check, the sale of Schedule 2 and 3 drugs, compounding and repackaging. But I want to kind of circle back here to person-centered care. Consider the example of standards 8.4.1 and 8.4.2. These standards speak to proper labeling of prescriptions. So what pieces of information need to go on a prescription label and when you're permitted to deviate from that. So the technical standards and even sort of dry. But when you consider 8.4, which is the outcome standard for that section, It says a regulated member supports patient understanding of their drugs by labeling every drug dispensed to patients in a manner that is accurate, complete, and clear. So this is why the standard exists, to support patient understanding. Read the outcome standard on any section and ask yourself, am I meeting that required outcome? And even if you meet all the descriptive standards but are still not meeting the outcome, then you have to do something else. The standards here, they're more than a list of simple rules to follow, and really no list of rules could possibly provide the answer to every situation. The standards are intended to make you think and quite often require you to make professional judgments to achieve that desired patient outcome. So that concludes my section of the presentation here. I think we'll take a short 10-minute break, and then we'll return to begin our Q&A panel for discussion.
All right, good evening, everyone. My name is Barry Strader. I'm the Communications Director with the Alberta College of Pharmacy. Thanks again for taking time out of your busy schedules to join us for this ACP Connect session tonight. I'm joined with three familiar faces who've already presented this evening. We have Greg, Jeff, and Monty. We're here to take your questions about the standards of practice for pharmacists and pharmacy technicians that were approved by Council back in June and will take effect in February in 2025. If you do have some questions or topics you'd like to explore with us that are outside of that topic, we invite you to stick around after the event and talk to one of our team members here, and we'd be happy to chat with you about that afterwards. So we ask that we stick to the standards tonight. And so we have two of our team members here in attendance with microphones ready to take your questions. We have over on the side there, we have Brett, and we have Danya over on this side here. So let us know if you have a question. We'll be happy to take that question. We also have an audience online tonight. We have well over 300 people joining us with our live stream of the event as well. And we invite everybody who is online, if you have a question, type it into the chat, and we'd be happy to address that question as well. I'm going to kick things off with probably the most important theme of the standards, which is person-centered care. And Greg, I want to ask you a little bit more about that and why that is such an important concept and, in fact, has its own domain within the standards.
So I think that there's maybe three elements to that, Barry. Really the reason that we exist and the reason that we have our professions is because of people. And people are individuals, as we know through our training, and if we look through the lens of drug therapy, we know that every individual responds to drug therapy in a different way. So therefore, strictly from a pharmacologic and therapeutic perspective, there's individual considerations that have to be met. But more importantly, when we talk about health, health is broader than just physical disease and mental health. If we consider the broader determinants of health that are so important to so many aspects of society today, it's important that we consider those in the context of individuals and families. So we need to understand them from a biological and genetic perspective. We need to understand them from a cultural perspective. We need to understand their beliefs and their preferences, because after all, at the end of the day, what we're doing is making decisions, and actually I should take a step back. It may not be our role to make a decision. It's our role to work with them, to assist them in making decisions to achieve their health goals. And so, therefore, it's important that at the center of every conversation is the person, is the patient. And we talk about person-centered care because it's a collective. It includes the individual, It includes us as their pharmacist or pharmacy technician, and includes other members of their health team. And therefore, we talk about persons as compared to simply the patient by themselves.
And we have a question from our online audience centering around person-centered care. This is from Sarah. She's struggling to understand the change in Appendix E, which indicates that a record requirement now includes the patient's sex assigned at birth. This is a harmful practice when not clinically relevant and contradicts the EDI work that ACP has developed over the past couple of years. Is there an opportunity to amend the language and guidelines around this requirement?
Hello. So something to keep in mind about this as well is that when it says includes, patient information includes, it may not require all of those pieces. So again, you need to exercise some discretion. So I mean, as pharmacists, you don't have to have a list that asks all these questions all the time. You're looking at the patient, and there are certain cases where having this information would be important to have. Of course, you need to balance that against the patient's the patient's preferences and their ensure that you respect their dignity and their and treat them as an individual who wants to be treated the way they want to be treated. But if you require that information, then it should be collected.
Okay, we have, oh, go ahead, Greg, if you had an additional comment.
Maybe just to supplement what Monty has said, and I'm sure that we'll get into this more as we go through the discussion of your questions, but I would come back to the person-centeredness, and I would come back to the concept of the outcome-based standards. So as Monty has indicated, you may not need to collect all of this information. It always has to be contextualized to the individual, and we need to treat each individual with respect. Okay, I think respect is a fundamental term that we need to have top of mind. And so not everything is for everybody, but it's important that collectively we understand the importance of these various concepts so that, again, we can apply our critical thinking and make the decisions in the context of each individual that we serve.
Okay, thanks, Greg. We have a question over here. Just ask you to stand up too, and Brett will help you out.
Okay, thank you. Hi, thanks for taking my question. I just wanted to clarify deprescribing. So it was presented in a way that all pharmacists, regardless of additional prescribing authorization or not, have the ability to deprescribe. The way I read it in the standards is that it is restricted to those with additional prescribing authorization. So would we be able to just clarify that a little bit further?
So thanks for your question. Within the standards, your interpretation is correct, that the process of prescribing and the process of deprescribing require similar patient assessments, especially in managing ongoing therapy. So currently we have just over 4,200 pharmacists in the province who do have their additional prescribing authorization. So we've structured it to fit within that process. Monty, do you have anything to add?
No, I think you've covered it.
Okay, we've got a question down here, Brett.
Oh, yes, thank you. Hi, my name is Kamal. I'm the president of the Alberta Cosmetic Pharmacists Association, and my questions is regarding to the personal services. Now, don't you think that by asking us not to introduce ourselves as a pharmacist, you are creating a double identity and putting patients at risk? Now, first of all, there is no regulation when it comes to that, meaning that, as a pharmacist, if a patient wants to make a complaint about the cosmetic injections, who do they go to? Secondly, since you put the personal services away from our scope, the liability insurance will not be included anything that's being done under personal services, this meaning that this process altogether is not insured. Now, Mr. Stanowich says that you can take a course online to inject a 2-year-old with no hands-on. All what you have to learn is marking, yet you failed to approve a training for Botox or fillers simply by collaborating with us, the Association for Cosmetic Injectors in Alberta, where we have been trying to communicate with you to establish some kind of training and put some frameworks. All what you have to do is just to cut and say, no, you can't do it. So if somebody come to me and ask me when I'm doing a Botox or a filler injection, what's your training and credentials? What do I say?
Okay, there are a few questions there. I think the first one was risk to the patient.
So I think that the policy underlying the standards has been well researched. I think it was outlined very clearly in the introduction that Jeff provided as to how we approached the development of the standards. As we've indicated, as we look to the concept of aesthetics, it is not enabled in at least 8 other jurisdictions within Canada. Excuse me, can I finish?
Let Mr. Eberhard answer the question,
Excuse me,
please.
Excuse me.
He looked in UK, New Zealand, Australia, where all of these pharmacists can do aesthetic services. And usually, no.
He's trying to answer the question, though, so just let him answer, please.
So we did a broader environmental scan. The second thing is that within the course of the past 2 or 3 years, and I can't give you the specific date off the top of my head, but the government of Alberta introduced the personal service regulation, which, amongst other things, regulates aesthetics. And it specifically recognizes this as a personal service as compared to a health service. The work of the Alberta College of Pharmacy and the authority that you are provided as regulated members comes through the Health Professions Act, established to regulate the provision of health services in Alberta. It provides a role statement for the provision of health services. It authorizes you as a regulated member to use restricted titles in the context of providing those health services. It does not provide latitude to use that restricted title for providing services that are not health services. So therefore, to provide a personal service that is quite separate and distinct in provincial legislation from a health service, it would be misleading to the public to hold yourself out as a pharmacist or pharmacy technician. In the event,
How about physicians and nurses?
I cannot speak for nurses, but I can speak.
We don't live by ourselves. We are integrated with other health professionals. Physicians and nurses, when they provide aesthetic services, they introduce themselves as physicians and nurses. You put us in a disadvantage this way.
Excuse me, Dr. Halak.
Yes?
I cannot speak for nurses, but I can speak clearly that physicians are recognized differently in the personal services regulation than other professions. So your question is out of scope, it's out of line, and it's inaccurate.
No, it's not. It's not. You are trying to
Nothing else.
All right, we've answered your question, okay?
I'm not satisfied with the answer. Like, I don't understand how Alberta College of Pharmacists cannot call up, like you invited the director of neuromodulator program at University of Alberta to get insight. So he was able to build a training program. Some of the pharmacists took that exact training program, and then you come and say there is no training program, pharmacist doesn't have the skills to do it. So when pharmacist doesn't have the skills to inject a 2-year-old intramuscularly, you go and you say, you know what we are going to do, we are going to do an online course where you can just see the landmarks and you don't have hands-on and you can go ahead and inject because family comes all together. You just say that health is not only about disease and prescriptions. How about look? How about mental diseases when it comes to the look? You don't look into that, or you just make things personal?
All right, you've had your say, thank you. Okay, we're going to move on to a question we had online from Janet. In review of pharmacy practice across Canada and internationally, she wanted to know what's missing that made the event and the new standards seem like there was not an opportunity to bring injection administration by pharmacy technicians.
Yeah, there certainly is provinces that enable technicians to administer drugs by injection, including Ontario and BC. This authorization here in Alberta comes through the Restricted Activities Regulation and through the health profession, which is part of the Health Professions Act. So in order to do that, it requires a regulation change. It can't be done alone within the standards. It's certainly something that we're carefully considering for the future and something that we've identified that we'd like to explore, especially as we learn more through our environmental scan and saw some of the progress that other provinces had made with it.
All
And
right.
Maybe
Go
Barry,
ahead,
to
Greg.
be more specific, I see Teresa here tonight. I think Teresa and I have a meeting on Monday to have a discussion about that very topic and what pathway PTSA might take to assist in the journey towards gaining that authority in Alberta.
We have a question here online from Talissa. Will ACP ever provide a description of an assistant's scope of practice versus a technician's? I find that carving out the role of a pharmacy technician in community practice rather difficult.
So, pharmacy assistant is a term that's colloquially used, but it's not a proper title. So, essentially, they're unregulated employees, and within the standards, the limitations of what an unregulated employee can do are actually laid out fairly clearly. As well, we introduced the concepts of critical steps and independent double checks because since they don't have any scope of practice per se, it's requires the pharmacist or pharmacy technician, a regulated member, to supervise them and to perform these checks. So really, their scope in the pharmacy, their purpose in the pharmacy is to support regulated members in providing certain components of patient care, and that's really it.
Okay, Brett, I believe you saw someone with a question. Oh, Dania, sorry. We'll just ask you to stand up so we can see you. There we go.
Hi everybody, my name is Karleen and I'm the pharmacy technician student. So my first question would be that from February 2nd, these new standards are in practice, but from which day these standards would be tested for law exam? So like I will be graduated by April and I have to appear for the law exam. So my question would be that I would be tested for the standards that our instructor taught us during the program or the new standards.
So that's a good question. Dania, our team, can we get this young lady's name? And I'd like to take that question away and we'll discuss it with the team and we'll provide you a clear answer so that, I think we have a responsibility to make sure that what you're evaluated on is fair and objective and relevant. And so I respect the question. And we'll make sure you get a clear answer. And we'll make sure that the answer we provide to you is communicated clearly to other technician students too.
Yeah, it looks like we have a couple of questions on this side of the room.
Oh, okay, sure. Hi, my name is Margaret Gray. I'm with Alberta Health Services. Maybe more of a clarifying question, and then if there's more meat to this later, I'll follow up after. The virtual care standards as they exist now, will they continue to exist when the new standards come in place, or are they superseded and rolled in?
Thanks for the question, Margaret. So those standards will continue to exist. They're part of the legislative framework. There are other sets of standards that we have, such as the laboratory and point-of-care testing standards and the standards for sexual abuse and sexual misconduct that will continue to exist as well. These standards will really replace the existing standards of practice for pharmacists and pharmacy technicians and the existing standards for the operation of licensed pharmacies.
Okay, I appreciate that, but it doesn't, these new standards talk about virtual care? I wasn't sure.
Yeah, one of the development principles was to look at the standards and to eliminate redundancy with the other sets of standards and to create bridges and linkages to those standards. So everything there should sort of dovetail where one leads you to the other, but nothing should be contradictory or redundant.
And you had a question.
Okay, we have another question back there.
Yeah, thank you. This may seem like a loaded question, but I think it has to do with patient-centered care. Pharmacy benefit managers are becoming more and more comfortable practicing pharmacy by making pharmacy drug therapy decisions and directing patients, thereby in contravening domain one, which is accessibility and choice of the patient. I was just wondering, I'm pretty sure regulations probably don't allow for ACP to directly contravene, but how will you collaborate with other organizations to get in the way of this huge situation that's quickly developing that'll really impact pharmacy care?
Complex issue, complex question. First of all, I think we need to be mindful that the evolution and the awareness around PPNs and the work of pharmacy benefit managers has a long history. It's not new. Significant attention has grown in the course of recent months and recent years because of some of the newer relationships that are being established by the pharmaceutical industry, by third-party carriers, and so forth. So I say it's complex because there are multiple role players that are involved. Your observation is correct. We cannot regulate the benefit managers, but we as regulators across Canada are having active communication about this. I think the lead is really being taken by Ontario right now. And I think it's fair to share that we are aware that the Competition Bureau of Canada has an interest in this subject and is learning about it too. So it's clearly on the agenda. I can't give you a clear answer as to what the outcome will be, but I would say there's more active discussion about this today than there's ever been, certainly through my career.
All right, we have another question on this side of the room.
Okay, thank you. My question is related to age 2 and over injections, the new standards came out. So it was said that different jurisdictions have different age limits, with some jurisdictions having no age limit. So is there a reason why we limited ourselves to age 2 and over? Or with Alberta having the most expanded scope of practice, what's the rationale, or why did we just not go with no age limit if there are different jurisdictions who have no age limit? Thank you.
Thanks for the question, and it's not an easy question to answer because it's difficult to know exactly what the right thing to do is sometimes. When we looked at the different age limits, we did see that there was a wide range. Only one province doesn't have an age limit for some things. Most provinces do have some sort of age limit. We took a middle-of-the-road approach, which is to pick something that we thought could be supported not only by the regulated members, but also supported by our partners, by the government of Alberta and public health, and something that would fit within the context of pharmacy practice. So that's why we picked the age 2. Certainly in the future, it's something that we'd be very open to exploring further change if no age limit would be appropriate or not.
All right, Danny, you have a question on the other side of the room here, it looks like.
Hi, my name is Craig McAlpine. The question I have is just around non-APA pharmacists. And so previously they were able to adjust the dose, regimen, and formulation on a new prescription based upon only weight, kidney function, and age. And I just wanted to understand the rationale for leaving that pretty much wide open now for them to be able to adjust it no matter what. To me, that kind of prevents like an APA pharmacist kind of maybe more required. But I just wanted to know the rationale for that.
Sure. So, I mean, non-APA pharmacists are still limited to doing these adaptations on new prescriptions. And we did find that sometimes there were circumstances that maybe didn't fit cleanly into those 3 boxes and would require, it would be appropriate for them to do so in that limited sense, but they weren't able to do so, and so it was impacting patient care. So really, that's where it comes from. But for anything like managing care or initial access prescribing, of course, that still requires APA. It was just a matter of, I mean, in 2007, I think, it was a new practice, like I mentioned, and so we put very careful walls around it. And here, from experience, we learned maybe we needed to expand that a little bit and make allowances when the circumstances required it.
That it's probably more of an exception. I think that it might be more. It might be good to clarify that, because I read that as like pretty much potentially opening the door for a non-APA pharmacist to be just adjusting dosages. So, yeah.
Okay, Brett, you've got a question in the back? Okay.
Hold the microphone. Would you mind standing up?
Yeah, so my question is, sorry, excuse me. My question is surrounding the new evolution in the supervision standards. So particularly in regards to pharmacist students and pharmacist interns, with the move away from that direct, indirect supervision sort of hard rules, it looks like it's now left up to the individual practitioner and what in their judgment is appropriate supervision. So I was just hoping for maybe clarification on that and if that is indeed the correct reading.
Yeah, thanks very much for the question. So, believe it or not, we're the only profession in Alberta that use the concepts of direct and indirect supervision. And we weren't certain that those worked effectively in reality. As Monty explained, direct supervision is really you standing beside the person watching what they're doing. And we sensed that that wasn't always happening. And indirect supervision at times felt like no supervision at all. So when we look to how we expect our regulated members to use the standards, which is to critically assess how they might fit in their practices, and if that practice includes having pharmacy students or pharmacy technician students, then you need to assess where it is, what's important for you to specifically observe and confirm when they're practicing. And because technician students and pharmacy students are learners, there's a process in which you may wish to observe them more closely initially, or have them observe you perform an activity. Then you would observe them perform an activity. And then once that they were able to perform that activity efficiently, you might enable them to perform that activity on their own. So it's really dependent on everyone in this room to critically assess how that would fit within their practices. And that's a model that is embraced by other professions.
You know, maybe another point too is that for those enrolled in structured practical training, there is a standard that defers to the structured practical training. So you may find more guidance will be provided through that program as well. The standards are sort of high level, and there'll be more detail on those specifics within that program.
Okay, Daniel has a question on this side of the room.
So my question would be regarding the domain 6, that according to that domain, we have to report all the close calls and the medical incidents to ACP. My question would be that there is also an introduction of just culture to that domain. So how the reporting of that close calls and medical incidents would be in future to ACP? Like even if we say like there is a close call that is not harming a patient, there was just a mixing of two medications in the pharmacy, it was a close call, but do ACP wants to know that yes, there was a close call in that pharmacy?
Thanks for your question. So the continuous quality improvement standards, they're really about looking at those practice incidents that occur and those close calls within your own environments and assessing them as a team. We don't expect that they be recorded or reported, I should say, to ACP, but we expect that the team be recording those and considering what changes they might need to make in order to either prevent that close call or that practice incident from occurring again. In the future, through the CQI Plus program, which will really incorporate medication incident reporting and close call reporting, that won't be to ACP, but that will be to a national database that's run through the Institute for Safe Medication Practices. And we think it's important that we share these experiences to that national database so that we can inform others about the medication incidents and close calls that are occurring and look to create systems that help prevent those medication incidents and close calls. So the process isn't punitive, it's actually supportive, and we're really focused on supporting Albertans in being safe when they receive pharmacy services. So I hope that helps.
Maybe just to supplement what Jeff has said is that the recording, again, not reporting, but recording and discussion amongst the team is not about accountability, it's about continuous quality improvement, okay?
All right, Brett has a question over here.
Yeah, for sure. I just had a question also about the injections for the 2 to 4. So I understand there's a course or some type of training that we'll need to do. So if, for instance, there's someone who does not wish to do that age group, is there some differentiation between someone who is and someone who doesn't, or is that just on the pharmacists themselves to identify themselves as, yes, I can do that age group, or no, I can't?
I mean, I think we have pharmacists that have APA and those that don't. We have those that have currently have injection authorization and those that don't. And like this, obviously, it's whatever you're comfortable with and whatever you feel is within your own personal skill sets. So no, it would be up to the particular pharmacist.
Oh, Brett has another one over here.
Thank you. My question is for Greg. So we live in technology world right now. And the other day I was reading something and then this popped up saying, you may not be in technology business, but technology is definitely part of your business. We live in that world. And with the arrival of artificial intelligence and AI, we have so many softwares out there right now that help us either do the documentation or reach to an assessment that helps us prescribing. So my question is, what is ACP's role, if there is any, in whether mandating or overviewing or monitoring the use of those tools that we have or we could use in our practice?
Great question, and I'm glad that it's a question looking to the future. I think we have to be honest with ourselves that the evolution of technology to assist in making decisions is going to continue to grow rapidly. I was pleased to just see this evening through the RXA's newsletter that there's an event coming up, I believe, on October 10th at the faculty, where Dr. Karen Ferris is going to be a guest speaker, talking a little bit about the advent of technology and how we use that in medication adherence and the roles of pharmacists in ensuring appropriate drug therapy. I think the simple answer that I would give you is that in speaking to other health professions, other leaders in the health professions. I think that those health professionals who embrace and who use technology are likely to be the most successful in the future. With that, however, will be the need to ensure that, again, critical thinking is applied and that you don't enable the technology to make decisions for you, but rather you use the technology to assist you make decisions. Okay? So you have to understand the limitations of the technology. You have to understand the risks with the technology. You have to understand the needs of the patient and the wishes of the patient. It's probably good to use some personal consent with patients when you're using these tools. And our college will continue to work with others and learn in this domain. I think part of your question was maybe what is the role of the college in regulating that? Again, it's not a decision that we will make autonomously as the Alberta College of Pharmacy. We will build our awareness as to what needs to be regulated when, along with partners, and that's why we've been very actively involved in the discussion around artificial intelligence with the College of Physicians and Surgeons of Alberta and with other colleges across the province.
You know, I think that with these changes, they're great potential tools for help, but there's a lot of risk there as well that needs to be considered. And I think, you know, with the existing standards, it really comes down to that, as Greg mentioned, like factors like confidentiality, informed consent, so they know that you're using AI and how their information will be used, and of course that the final judgment rests with the pharmacist, and the pharmacist has to be aware of maybe the limitations, like where's the data coming from, are there potential biases in the data, so it's not making the decision for you. It's like any other information or data you would consider, whether it's a textbook or talking to a colleague or using AI, you have to critically evaluate it and make sure that what it is appropriate for that patient and that you're the one who makes the final decision on it.
And I think a closing thought on that, for a number of years now, there has been a curiosity growing around the needs for competencies for health professionals in digital health. And that discussion has grown rapidly into the international arena, where the International Pharmacists Federation is now talking about developing competencies for pharmacists in digital health. So my purpose in bringing it forward is to submit that in the future, I expect that competencies for digital health will at some point be introduced as a critical factor within pharmacist and pharmacy technician practice.
Okay, I see we have some hands in the room here, but I wanted to make sure we didn't forget about our online audience. We do have a question going back to the immunizations for children 2 and over. This question from Krista. Do we know if children 2 and over will still be immunized by public health for routine vaccinations, or will all vaccines for these age groups now be the primary responsibility of community pharmacists?
Yeah, I can help answer that question, Barry. So we've had some discussion now with Alberta Health Public Health, one, to make them aware of this change within the standards of practice, but two, also to begin to make them aware of the opportunity that could be played by pharmacists in the community in administering these injections. They're certainly receptive and they're certainly interested. They do control eligibility to their programs. And so I suspect that given our success, especially with influenza and COVID-19, that will be an easier discussion. Looking at other vaccines in the future, we'll hope to build from there.
Great. Thanks, Jeff. Okay, we'll go back down to Craig. You have another question.
Yeah, Craig McAlpine here again. Standard 8.1.2a, prescription duration. I still struggle with this one. I know there's a federal regulation with benzodiazepines that kind of, is set, and ACP can't control that. But in general, I'm just trying to understand, with first fills can't be filled more than 1 year before the date the drug is to be dispensed. I don't really understand what is the date. Is it like, I don't really quite understand that, and I just don't know why it wasn't just written date, maybe. But maybe there's a rationale for that. Maybe a prescription is written and the doctor specifies fill in 4 weeks or something. So maybe there's rationale there, but I'm trying to understand because it's just very confusing to me.
So is it the language, Craig, that's confusing in the standard you're saying, or is it like the rationale for?
Yeah, so refill of benzodiazepines are 1 year from written date. Regular RXs are 18 months from first fill date. First fills can't be filled more than 1 year before the date the drug is to be dispensed. So there's like 3 different terms there. And then, I just, in the end, maybe it has to be that way because of the federal part. But I guess my main question is, could we not have just said written date for the first fills? At least that would have been a little bit simpler.
And maybe, really the rationale here for the first piece is that if a prescription was written a year ago by the prescriber or more than a year ago, is it still valid? Or do they need to be reassessed either by the pharmacist or by going back to the original prescriber? So, that's why that limit is there. In terms of the benzodiazepines that does come from federal legislation and federal requirements. So it's in the existing standards and it remains there because that particular legislation hasn't changed at this point.
Dispensed. What does that mean? Is that the written date, or is that
issued to the patients? I would say the written date, yes.
Craig, based on your feedback, we'll take that one away, and we'll look to see if we need to create a link article or further guidance around it. But thanks very much for highlighting that.
All right, we'll go back to our online audience now. And Mary had some questions on the aesthetics issue. She said, can an individual who is a regulated member work as an aesthetic injector outside a pharmacy and not identify themselves as a pharmacist?
So again, the standards are specific to pharmacists and pharmacy technicians, and the standard under the SOLP is specific to pharmacies. And what it says is that a pharmacist or pharmacy technician cannot provide professional or personal services and hold themselves out as a pharmacist or pharmacy technician. So if a regulated member chooses to provide aesthetic services, they're free to do so, but when they do it, they cannot hold themselves out as a pharmacist, and they cannot hold themselves out as a pharmacy technician, and they cannot perform those services in a pharmacy.
She has a follow-up question also. If aesthetic injections fall under personal services regulation, would an individual need to be in a capacity that is authorized to perform a restricted activity like injections to do Botox?
The personal service regulation does not recognize restricted activities. Restricted activities are an artifact of the Health Professions Act, which deals with health services.
All right. I'm scanning the room to look for some other hands. If anyone has any questions, we have another one at the back here. Just a heads up, we've got about 5 minutes left in our session, so if you do have a question, make sure to put your hand up. Go ahead.
Yeah, so just a clarification around the drug repackaging standard with the performance of a final check, how that is intended to be implemented around centralized pharmacy services. So if something's being filled in a central location, checked independently by a technician or pharmacist in that central location, then sent out to a community pharmacy for final dispensing to the patient, is that independent check done at that site by that regulated member sufficient, or is there a final check that needs to occur at the secondary site before delivery?
Sure.
Give me that.
There's always a need for a final check by the health professional who is providing services to the patient. When you're involved in providing a drug to a patient, you always share responsibility and liability, regardless of what has happened prior to you receiving the medication. So our standards require the pharmacists and pharmacy technicians at the forefront who are dealing with the patient to provide a final check.
I'll just add to that. I think, too, it's really important that the pharmacy that has the direct relationship with the patient also have that direct responsibility for the final check. One of the things that we looked carefully at was information from the Institute of Safe Medication Practices, and they've repeatedly highlighted in medication errors that the final check being performed at the pharmacy that dispenses the medication to the patient and has that patient relationship, that final check is a critical component of preventing errors from occurring. So certainly something that we valued learning from ISMP and reinforcing from them as well within our standards.
Okay, we've got one more question from our online audience. This is from Janet, and she's referring to assessment that takes place before a professional service is provided. How will that work when often the first contact in a pharmacy is with an she says unregistered, I'm assuming that means unregulated individuals.
I would encourage all pharmacy practices to move to a behavior where the pharmacist is the forefront in working with the patient, and that technicians are the ones who are doing the technical work and take the responsibility for the processing of prescriptions. There is risk. There's clearly risk if we rely on unregulated individuals to be at the forefront dealing with patients. They might be able to receive a piece of paper. They might be able to receive demographic information to assist in identifying the individual, but they do not have the knowledge to ask the critical questions that are important to assessment, and certainly they don't have the knowledge and skills to ask the secondary or supplementary questions which might be necessary for the assessment. So I think the new standards really encourage some new thinking about how we develop workflow within pharmacies, how we use the pharmacy workforce, and who needs to be positioned where to ensure that assessment occurs, because assessment is the route to everything.
And Barry, just to build on Greg's answer, it's one of the things that the new standards clearly establish is that you can't defer the forming of a professional relationship to an unregulated individual. So pharmacists and pharmacy technicians are responsible for forming that professional relationship and taking care of that individual. Now, that's not to say you can't use unregulated individuals in the process, but the ultimate accountability is with the pharmacist and the pharmacy technician.
All right, we're almost at our time for this evening, so I just wanted to put one last question to each of you. I'll start with you, Greg. What's one thing you hope that people in attendance here tonight and those tuning in online will take away from this event?
I think the most important thing to do is to walk away and understand the concept of the outcome-based standards as compared to what we've had in the past. The beauty of the outcome-based standards is that they support pharmacy practice across all practice sites and all practice locations. When we look to the descriptive standards, some of those may be more important depending on the population being served, depending on the type of service that's being provided, depending on the team that you're working with. But in all cases, the outcome that you want to achieve should be highly common. And so you will always want to critically think about how you use the descriptive standards to understand the context important to achieving the outcome that you're obligated to achieve. That's a big change.
Jeff, how about your thoughts?
Yeah, thanks, Barry. And I think I really encourage everyone in the room to carefully think about how these standards apply in your practice. They're meant to be individualized to what you do and the care you provide to your patient population. So I encourage you to sit down with your colleagues, with your pharmacy friends, whomever, and think carefully about how you wish to implement the standards within your own practice.
Monty, I'll give the last word to you. What are your final thoughts?
Sure, thanks, Barry. I think there's 4 months until the standards come into force, so that provides ample opportunity to, building on what Jeff said, have a look at the standards, see how they're going to change your practice, how they're going to affect your practice, begin to make changes to policy and procedure. If you want to deliver or administer injections to those 2 years and up, look at getting the training now and doing that. As well, ACP is going to provide additional information over the course of the next 4 months. So I encourage you all to keep your eyes open and read that information as it comes. And if they have questions, please provide them to us, and we're happy to answer them.
Greg has one more thought. Greg? Got to give Greg the last word.
So in Alberta, we've been privileged, and we've had a lot of celebration, and we've had a lot of discussion and shared a lot of pride around scope of practice, particularly with pharmacists. I know we have ways to go with technicians, and we will work with technicians to move things along. But in pharmacy practice, I think it's important to reflect on the past and understand what it means to us, but to understand that application and use of the new standards is critical to keeping pharmacy in Alberta in the forefront. If we don't successfully implement assessment as a foundation for all practices, consistent with every patient, whether we are a pharmacist or whether we are a pharmacy technician, the concept of our scope of practice really doesn't matter. The rest of the world will pass us by. Okay? So these standards are really important to where we have come from, where we need to go, and they're going to raise pharmacy practice in Alberta to a different level that the world will continue to look upwards to.
All right. Thanks very much, Greg, Jeff, and Monty for joining us this evening. Thank you for coming here as well, and those of you who joined us online, we really appreciate you spending a couple of hours with us. We know there's lots of ways you can spend your time, and we appreciate that you took the time to join us this evening. I should also let you know that coming up in the spring, we will have another series of ACP Connect events that will focus on the standards for the operation of licensed pharmacies. So that will be a really good opportunity, in particular for licensees and perhaps even proprietors' representatives to join us in a discussion about those standards. So keep your eyes open for more information about those events early next year. So once again, thanks for joining us. Have a wonderful evening.